Welcome everyone to the Advanced Patient Care, a podcast series by Vance Thompson Vision. Today's podcast is When the IOL Isn't Forever, Managing Dislocated IOLs, featuring Drs. Lorraine Zimprick, Kristen Walton, and I'm your host, Matt Walker. So let's talk next about symptoms. So that's what, a lot of times the origin of it. But what are patients complaining about? I would say one of the biggest ones that we see here is no symptoms, where we get a referral, from their doctor. Hey, this patient has a dislocated lens. And we come in and ask them what their symptoms are, and they say absolutely nothing. I'm happy with my vision. My doctor saw this, and we want to figure out what's going wrong. As that implant starts to sink, or even sideways or up, sometimes it'll even happen. When that implant's not centered or the lens isn't centered, the second probably biggest one they complain is vertical double vision or diplopia. Sometimes just blur. They just experience just not clear vision. Or, hey, I can see, but everything has a flare to it. Those are some pretty common ones. The one I don't like to see is if patients say they're having those symptoms and randomly my eye just is incredibly painful. We get concerned that as that lens is dislocating, sometimes it can close the front chamber of the eye, causing intermittent angle closure, and that will cause pressure to rise significantly, causing eye pain, comes back down, comes and goes. And so not only is that not good for vision, but also for the health of the eye and optic nerve integrity. What do you guys see in your practice?
I would say about the exact same.
Okay.
Sometimes it's light sensitivity, irritation, red, irritated eye. And that's from a number of things. If that lens is dislocated and it's touching the anatomy in front of it, which is the iris. If it's touching the iris and like chafing on that, then you're going to get cells, pigmented cells, irritation from the iris cells that go into the anterior chamber. And, that ends up being inflammation that causes this light sensitivity, redness in their eye. And so, I think it does range. It ranges from no symptoms all the way to the extreme excruciating pain that comes intermittently. Everyone's a little bit different, but yeah, a good range.
I would almost say too, from a referring OD standpoint, if you have someone that has a dislocated lens, get those symptoms from the patient. I would say if they're having any, I would just bring them in so then we could take a look to see, is this a concern for the patient, something that needs to be addressed, or is it something that could be monitored every 3 to 6 months? So again, just because it is dislocating doesn't necessarily mean that something needs to be done about it.
Yeah, I totally agree. And sometimes it is dislocated just a little bit.
Yeah.
And they have no symptoms. There's no inflammation floating in the eye. It's not touching the iris, and that's sometimes okay to leave and just watch,
Especially taking into account like age of the patient and overall health of that patient too. Are they healthy enough to go back for surgery? And if they're not noticing any symptoms, then yeah, absolutely monitoring.
Sure. So next up, we're going to talk about what are the different types of dislocated lenses. I mean, it's one topic, but there is more than one way that this lens will start to dislocate. One that Dr. Zimprick had mentioned was this denesis, where there's a vibration of some part of the anatomy. So phacodenesis is when the natural lens in the eye wiggles, vibrates, and that's usually because there's been some damage to that zonular complex. But they can also happen after cataract surgery, pseudophacodenesis, where that implant in the bag can also vibrate, and that again is an increased risk for IOL dislocation. And it can happen to the iris too. So sometimes we'll see, because a lot of times when we're in with our eye exam, we don't get the ability to go in the eye to kind of feel how much zonular support is there. But if we see that there's shakiness to the iris, there's a chance that the capsule and the lens could be involved as well. And just relaying that to us or our surgeon, I think helps everybody to prep that. Beyond that, again, Lorraine had mentioned as well, there could be, Dr. Walton did, where there could be the simple lens decentration, where the lens, whether it's natural or your implant, is off a little bit, but things are going well. to partial subluxation, where we see that lens really starting to move out of the way of the center of the pupil, messing with quality of vision. And then there's number 3, complete dislocation, where the implant can typically, when it starts to dislocate, it'll go into the back of the eye and either rest on the bottom of the eye in the retina, or be kind of suspended in the vitreous. And sometimes it can be either in the bag where the capsular complex goes with it, or number 2 is that if there's a capsular tear, the implant could just drop out of the bag. So the bag still remains, but the implant drops to the bottom of the eye. We've seen a few of those, and as it gets kind of worse and it's becoming more retina involved, we get concerned that there's a risk of issues with retina, retinal detachment risk, vitreous hemorrhage that could mess with quality of vision there.
Yeah, and I think that's one of the biggest things is like when they come in, how loose is that lens? The lens that's decentered is like, how loose is this? Is it just decentered and you're kind of knocking on your slit lamp and the lens is like staying right there, it's not moving, it's maybe been that way for a while? Or is it something that we're worried is going to fall to the retina within the next day? That of course helps us with urgency of surgery, because the last thing that we want is for that lens to fall into the back of the retina. Now we all of a sudden have to get retina specialists involved. It's just a much more complicated surgery, getting retina involved, putting in that lens, the whole complex is gone. And so that helps us with urgency a little bit too.
That's great. Dr. Walton, let's talk about what are the complications of dislocated IOLs?
Yeah, and most of the complications come from just having this foreign object in the eye and not being in the right place. And so you get a lot of rubbing and irritation that's happening where it shouldn't be. So we can see that chronic recurrent uveitis. You had touched on uveitis early of being a cause, but it could also be a result of constant rubbing and irritation from that dislocated lens. And then that's going to break down blood aqueous, blood retinal barriers. And then that can lead to macular edema. And that can lead to, we can also start to get UGG syndrome, where we get uveitis, glaucoma, and hyphema. Again, from that constant irritation, we get high pressures, and then we get bleeding that we can't control because the iris keeps irritating, or the lens keeps irritating the iris. We can get some corneal edema and decompensation as well. If that lens dislocates to the anterior chamber, yes, that's a higher risk. Same thing with just anterior chamber IOLs. I know we don't see a ton of those here. I don't know about you guys, if you guys had a practice around you that used them quite frequently in the past, but I think those are becoming more and fewer in between than what's been done in the past. And then irregular pupil and transillumination defects. So again, if that lens is constantly rubbing behind that iris, we're going to start losing that pigmentation, and starting to see those. I think the transillumination defects, if you're seeing the pseudophacodenesis, and then you're starting to see TI defects, that's when you're going to have to start watching those patients really closely and think about getting it in for a consult, just so we can avoid more of these complex issues that come across with IOL dislocations. I don't know if I've necessarily seen any retinal detachments with IOL dislocations. I don't know if you guys have in your experience.
I don't think I have as a result. I don't think so. I know that's one of the, things that we watch for, and we make sure that they have a good retinal exam prior to surgery, after surgery, just to ensure that everything looks good. But I don't think I've seen a retinal detachment. Certainly seen probably all the other stuff that has come with it.
Yeah, I know retinal detachments is on the list, but that's pretty far down that list for complications. And then, as you said, kind of getting into diagnostics of what we do when a patient comes in with those issues, wanting to make sure that we have a good anterior segment exam, figuring out what the root cause may be for this IOL dislocation, figuring out where the lens is. And then that posterior eye exam, if we have a retinal detachment, getting a consult from retina if we need to, or do a combo case, those types of things. If we start getting into UGG syndrome, or we have severe hyphemas that come along with these dislocations, sometimes we need other equipment than just an exam that we can do with a BIO. So we get a B scan or an anterior segment scan. And sometimes that's not enough. And do you guys have ultrasound biomicroscopy? I know that's just a little bit more detailed than a normal B scan or A scan, but I think with us, those, an exam, a B scan, an anterior seg, usually that's enough for us to know what we need to do and get in the eye and fix it.
Yeah.
We had one case, we don't have UBM, but one case where the lens is gone. The patient had cataract surgery. They're aphakic now. We tried to look in the eye, and it's like the top zonules, everything lost except for the bottom zonules. And so it flipped to the bottom of the eye, and it was almost impossible to see, but we know it's there. Like, no one took it out, and UBM was done by a retina specialist and was able to see it. I mean, normally it's a no-brainer. It's right there. You can see it. It's just the anatomy of the eye. It almost tucked back underneath where it was a challenge to see.
That actually happened to me.
Yeah.
I was a newbie here, trying to get my bearings around here, and a pretty high profile guy came in. He hadn't been seen for a while. He had severe glaucoma. He had some referral notes, but again, it'd been a while. And in those notes, it said he had an IOL in that eye. And I looked at it and I was like, I don't see that.
There's the IOL.
It's not there. And so I did a good dilated exam. We did a B scan, could not find the lens. So I'm like, did somebody take it out? He had no recollection of that. So we did send him to retina, and the retina doc did find it. But key note with that, if you can't find the lens, to lay the patient back. And then that lens sometimes comes back into view to be able to see it if it is tucked up in close to that iris, so that you can't see it yourself. So it makes you feel better that you can locate that lens.
Yeah, it brings you back to the days of proficiencies in school and stuff, where you were doing indirect or BIO and you were kicking them all the way back and doing it in the chair. We've had to do that a couple times to try to figure out where the lens is, and sometimes you just lay them back and it's enough that lens will be dangling in the vitreous.
Got it.
Yeah.
Interesting.
One other thing I was going to add to that with the diagnostics is, if they do have TIDs, we like to take a picture of the TIDs, just a regular external photo, just again, because when you do that surgery, one of the things you watch for is afterwards is increased TIDs and worsening of those. And so it's nice to have a good baseline. I think that's really important as well, just documenting where the TIDs that are already present prior to surgery, just so you have a good watch on if something is changing afterwards.
That's a really good point. And with the TIDs too, if they're severe, obviously number one goal is to improve vision with how dislocated that lens may be, but also talking to the patient about possible light sensitivity afterwards, just because the iris isn't functioning the way it should. I think, that's a really good point. Also with diagnostics, I know we kind of work them up just like a normal cataract eval too, just to see what the cornea looks like, see what that macula looks like, if there is any macular edema, just to be able to give them some gauge of what that visual outcome should or would likely be after we get that lens in position.
Yeah. And I think as referring doctors to us, if we didn't do the surgery, it's helpful to get the ball rolling of where did they have the surgery? What lens do they have in their eye? Is it a single piece, a 3-piece, PMMA? What type of lens is in their eye? Because that matters a lot when we're deciding what surgery to do and how to position it correctly. And so, a little bit of getting that ball rolling, so that if we didn't do the surgery, the patient can come prepared as which lens is in their eye. Or typically they get a little card with what lens they have in their eye, and if they can bring that or they know what lens it was, that's helpful too.
For sure. I have a question for everybody. When you see UG, how often is there hyphema?
Not very often.
Yeah.
Yeah.
Because in our training, same thing, like, okay, I see uveitis, I see glaucoma, but there's no hyphema, so then it can't be UG. No, guys, to me, if you have somebody that has uncontrolled glaucoma, meds aren't helping, they've had cataract surgery, maybe they have a couple TI defects, they don't even necessarily need to have uveitis, but maybe there's some low-grade inflammation there that you can't even see. It could be UG. So, and again, that's really a big uphill battle when you're trying to deal with chronic inflammation. We've had patients that have gone, through trabecular stents and Omni, and no, like that's not, it was, the problem was the implant and that whole process. It's an uphill battle to treat medically. So for, ODs and surgeons out there, if you have this glaucoma patient that's not following the rules, medications aren't making sense, they are pseudophakic, really take a look at the implant. Is there an issue? The other thing that we've seen is, well, yeah, they have glaucoma and oh yeah, they had Fuchs just in one eye, and they've had a DMEC or a DSEC. Well, no, why? And the other eye is crystal clear. No, there's a problem with the implant. That's UG2 that led to that corneal decompensation. So looking just beyond like the individual things that you see, I think in my UG that I see, I don't think I ever see hyphema, to be honest.
I maybe see a few
Go
RBCs every once in a while, but yeah, no like outright settled hyphema.
Yeah.
Yeah, I would say I see it in that order, right? You almost see like uveitis, low grade inflammation, increased pressure or pressure spikes, and then that turns into glaucoma. And then of course, if you're going to let it sit long enough and have uncontrolled pressure and things like that, then it will eventually lead to that. One of the other things is like, we were talking about how patients present. Sometimes they present, no symptoms, just like Matt had alluded to, but pressure of 40.
Mm-hmm.
And so no symptoms, but a pressure of 40, that's still not okay. Their, optic nerve might be good and okay and no RNFL loss now, but give it a year, 6 months or something, and there will be loss and we will be dealing with UG syndrome,
Right.
Yeah. And I think UG syndrome is one of those issues that we see that in school you're taught all of these like textbook ways of how things present in the eye, and nothing is ever textbook. And again, UG, I think, just fits that to a T. It's like it's never exactly how you expect it's going to. And when you've been following a patient for a while, and I know sometimes I get this way of you get pigeonholed on what you think you're trying to follow and treat. And so then you have all these little pieces, and sometimes you just need to take a step back so then you can say, okay, well, how do all of these fit together? Maybe they're not all individual problems. And I think that too is, maybe you don't practice in a group practice where you have somebody to bounce ideas off of looking for a second opinion. I don't think that's wrong to send out and just say, hey, can I just have you put your eyes on this case to help me put the puzzle pieces all back together?
Love it.
One other thing I was going to mention for diagnostics, sorry, before we move on, and you kind of said that, any picture of, like, we'll often do that, whether it be post-op, pre-op, is take an anterior seg photo and try to get as far posterior as we can. And you'll actually be able to see if that lens is touching the iris or not. And we'll use that too, even after surgery, if they still have some like lingering inflammation, and then or post Yamani or post whatever, we'll take a scan just to make sure that that lens is sitting far enough away. And so, even if you have one of those patients that, again, nothing is making sense, they have these pressure spikes, no complaints, some TIDs, sometimes it's worth getting like an anterior seg OCT or gonio, of course, to see if that lens is touching when things don't make sense.
So moving on, Lorraine, we have this patient has a dislocated lens. How do we fix it?
So there's a couple different ways, and we chatted a little bit about it, but a lot, of course, matters on what lens is in their eye. And if it's a 3-piece lens, if we're going to try, or 1-piece, whatever, if we're going to try to save that lens, if we can go in the eye and we can use the lens that the patient that's already in the eye, that's going to be less inflammation, faster recovery. It's going to be a little bit easier. And so, generally there's 3 different ways that you can either situate the lens in correct position. One is going to be like a transscleral suture, or like a lasso, or a belt loop, something that we can, if that exists, that lens is in their eye, and you can, exactly how it sounds, lasso or belt loop that lens to correct position. That's going to be, I would say, surgery itself, is complex regardless, and has all sorts of post-op complications. But that is one of the ways, if we can do a lasso and lasso that lens to raise it up, and get it in good position, that is one of the most common ways that we do things. If that, and that's when the complex itself is still there, and it's just, everything is shifted a little bit, but the whole complex itself is still there. If that whole capsular complex is not there, and the lens is, completely discentered, or we can't use that capsular complex, then we're going to have to use a different way to get that lens into position, because we no longer have that, that tissue to help center it. And so then we're talking about a little bit different situation, where we do what we call a Yamani technique. And in the Yamani technique is essentially where there is no complex, but we have to take the arms, essentially, of the lens. So each lens has little arms or haptics to it, and we have to take those haptics and we have to essentially use those arms, and we hold them up, or put them in position via the sclera. And so, there's nothing else that can hold the lens in place besides these arms that go through the sclera and sit, with the white part of the eye. I would say we probably are doing that more. I don't know if just it's the patients that we're seeing, having like complete decentration, and that's just what we're seeing more of. But I work with Dr. Terveen, and he's doing more of the Yamani techniques than anything. I don't know what you guys do most.
Yeah, I'd agree. I think we do a lot of Yamani. Dr. Bartman's getting very comfortable with that. Initially, when you're threading those haptics through the needles and through the sclera, some surgeons were noticing that no matter how well you feel like that lens is unfolded in the eye, that those haptics could get twisted. And then once you thread them through the sclera and you use the cautery and make the little flanges to hold it in place, then those haptics start to settle in the eye. And then instead of the IOL looking at you like it should, nice and straight and flat, then it starts to, what they call rotisserie chicken in the eye. So then it starts to rotate.
I agree.
I haven't heard that.
I like the rotisserie. I would say from our end, we, especially someone that has an advanced technology lens, let's say they have a trifocal or EDOF, if there's a chance to save the EDOF, let's do it. Belt loop from our end has worked very well. But if there's no way that capsular bag complex is going to survive, Yamani, I think, is a great way to go. I read a paper, kind of a pro-con, because it's either you suture the lens or you use the haptic, to transscleral haptic fixation instead of suture fixation. And Dr. Walton's right that when you do a suture fixation, you use 4 sutures and you can stabilize that lens to keep it more perfectly centered. The Yamani has a little bit of a tilt with it, but there's no sutures with Yamani. it's a faster surgery. Patients are more comfortable, versus if we use incisions and a Gore-Tex suture, for example, 7 millimeter incision sometimes is what's needed, 4 of them, longer surgery, more difficult recovery for patients. I think what it comes down to is surgeon preference and maybe a little bit of training, where if hey, I feel 1,000% confident more with the suturing the lens in versus using Umani, and these are my outcomes, great. But I would say that we're seeing way more surgeons that are using Umani, including Dr. Kramer here in Alexandria.
Yeah, I would agree. And even, you were talking about using sutures sutures, I guess, to hold that lens in place. Sometimes those sutures can erode. And so the most common one that they actually used to use was Prolene sutures. And, they at first it looked like it seemed as a great option. People were doing well, but then they started having these patients come back and those sutures were eroding and not working out as they planned. And so now they use the different one, as you had alluded to before, like Gore-Tex sutures, which are, stronger and more durable and last longer, is what we're finding.
Yeah, and with that erosion, obviously, if you're eroding the sutures, then the stability of the lens is gone again, but also very, very concerned about risk of endophthalmitis and completely losing that eye. So if we can avoid that, obviously that's best case scenario.
Sure.
And I always tell my patients too, it's like this surgery is not as simple as cataract surgery, right? Cataract surgery is 5 to 10 minutes. And this is much different than that. The recovery is much different. Everything is much different when we're talking about trying to get that lens back into position. And so even recovery is much different. And when we're managing these patients post-operatively, some of the most common post-op, considerations that we take into place is some of the exact symptoms that we had before surgery, right? Pressure spikes, corneal edema, decompensation of the cornea, macular edema, bleeding or pigment cells floating around. And so those things, sometimes you can just treat with drops until we get a little bit further out in the post-op period where, their prednisolone or whatever that they're on, that inflammation can decrease so that pressure can become a little bit more stable. So a lot of times we have them on multiple drops initially, and then we start taking those off as the healing, as the days go on and the healing improves.
Yeah. And I think chatting with the patients too about, possibly having early IOP spikes, just because like you said, it's a longer surgery, it's more complex, we're going to have more inflammation, so you expect that. Same thing with corneal edema. Maybe you didn't have it to begin with, but maybe you have it afterwards just because of the complexity of the surgery, but that should resolve over time.
Yep.
And with the bleeding too, if you start to do suturing, if you start to do Umani technique, you're going through uveal tissue, just keeping in mind that patients, and a lot of these patients tend to be elderly and on blood thinners, that we have to have that conversation to stop those so we can potentially eliminate having a major hyphema afterwards.
How soon do you have them, or, before surgery? 2 weeks?
Usually I just have the conversation in the room. And then depending on what blood thinner they're on, sometimes it can differ, but really ultimately leaving it up to their primary care doctor.
Yeah.
Just so that we're not responsible for taking them off a blood thinner and then having complications from that.
Yeah. I mean, the bleeding will always stop, right? It's just, it's a lot harder recovery post-operatively if they do end up having hyphema. But yeah.
Or vitreous hemorrhage. That's never fun.
Yeah. And I think another one is, of course, it depends on what surgery you do, but if the patient has sutures, like corneal sutures or conjunctival sutures, like when do you remove those? Sometimes initially, even at like 1 week, if they have sutures, I'll just like clip those sutures. Sometimes 1 week is a little bit too early to start just removing everything. And so I'll leave them as long as I can, but clip them if the tails of that suture become exposed. I don't know what you guys are doing, but then as far as corneal sutures, you know, at 1 week, if there's no swelling and everything looks good, I'm comfortable removing that corneal suture. Otherwise, I'll do it at 1 month if needed.
And yeah, that sounds pretty much what I do, but also it depends on suture or incision size. So if we're removing, you know, if we have to remove a PMMA lens or something where you can't break that up in the eye, then you got to make a large incision. And so then I'm probably waiting until at least 3 months to take those sutures out. But anything with a smaller incision, yeah, probably a month or so.
Yeah. Yeah, I think it's interesting, you know, when we go in to do cataract surgery, the lens, you know, the cataract itself comes out in all tiny pieces, and the lens that we put in goes, you know, in wrapped up through a tiny little incision, right? And then when it gets in the eye, then it opens up. And so when we're taking that lens out, we can't just roll it back up and get it through a little incision anymore. It has to, if we're not going to use that lens, then we're going to have to take that whole lens out, you know.
Sometimes you can cut it up
and that can require a larger incision.
Yep.